afternoon. Welcome to the Social Determinants of Health Work Group. I'm the moderator, leader along with the co-leader, Ms. Luz Rivera, who is not here today. Filling in her place is Mr. Roger Chavez. Roger is working also in the public health service along with Ms. Luz Rivera, who unfortunately could not join us due to surgery. But we're happy to have Roger join us. Before he starts, I have a couple of slides to introduce the actual group, which is the Social Determinants of Health Work Group with Howard. I have a few slides I want to share on exactly from a primary care perspective and public health perspective, the social determinants of health and as it pertains to public health, social service, and primary care. I'm going to begin by sharing my screen. Just a moment, please. So addressing social determinants of health. This is a small slide taken from the American Medical Association. I wanted to share a little bit more about what happens beyond the clinical walls. How can we translate or improve health outcomes by addressing social determinants of health? What are social determinants of health? According to the AMA, social determinants of health have up to 6 times the impact on health as compared to clinical care. Addressing social determinants requires collaboration across medical care, public health, and social service providers. So in the context of public health, primary care, medicine, and also in terms of social services, what are social determinants of health? These are conditions in which people are actually, born, grow, work, or live and age in. Things that we can't necessarily change. They're already determined based upon the current standing or current present situation of a population of health of patients or a group of people. And the wider set of forces and systems also that are shaping their conditions in daily life. That could be economic, public policy, the laws and rules of the land also. So in terms of economic stability, we have employment, income, expenses, things that can happen. For instance, somebody who runs into a major illness in life and takes on a huge amount of medical bills, medical debt, these things can determine and often, turn their health status around. Whether or not they have insurance, health coverage, depending on the healthcare system, what it provides, whether it's a socialized system or more like a private insurance type or HMO, PPO, all these things that, or Medicaid, Medicare, the type of insurance a person has determines also what types of health coverage they might have. A lot of people who fall in the safety net, who don't make it, maybe are undocumented and are not necessarily following their healthcare coverage, can find themselves in difficult health circumstances. In addition, neighborhood and physical environment, as we mentioned, transportation, where you live really actually can really determine how your overall mortality, morbidity, life expectancy, all the health outcomes can really change depending upon your income status and where exactly in the ballpark in terms of the health of your own neighborhood. Are there sidewalks available in your neighborhood? Are there parks and are there healthy food choices available in your neighborhood? also, and thankfully we live in a country where we have a lot of opportunities for public education for our children. So early childhood education. Some people might not have access to higher education if they can't afford it. Those things determine your long-term health outcome, long-term income. It determines your long-term ability to make a life and a career for yourself and your income status. And so really what opportunities are afforded to you based upon your particular income bracket, your ability to overcome discrimination, racism, things that might divide, things that we might think, America is the dream country where everything's possibility for people. Certain people might not, because of particular policies. For instance, if you're undocumented, you might not get, the ability to have maybe child support if your loved one is across the country, across the borders, and you can't have somebody to look after your children. So many of those issues. Excuse me, I'm just going back to the past slide. It's like almost a net of public health circumstances that determine what your overall health will be. So what are the real 8 steps according to AMA to address social determinants of health in your particular practice, in your particular work group, or understanding and engaging your community is number 1. I was trained as a public health practitioner at George Washington University's Milken Institute School of Public Health in community-oriented primary care here in Washington, D.C. And so one of the first things you do in the community-oriented primary care model is to determine which community you're a part of and elicit an overall, basically key health indicators and maybe like provide a portrait of your community. Know who you're dealing with before you come in and try to influence them with your particular public health policies or what knowledge you have of socially engaging that community. It helps to be a part of that community, helps to be a part of understanding how that community came about. For instance, if you're working with people in Anacostia and you're wondering, how to engage with the people of Southeast Washington, D.C., you have to understand their cultural and actually like the determinants of health amongst the African American population there, a lot of the poverty that exists, the housing discrimination that existed over time, transportation issues. Again, linking back to the past slide that we just discussed, understanding where they come from, and then also engaging key leadership that influences that community. So what we did, and I'll actually go over a slide of my own particular research findings regarding mental health in a particular primary care practice in a rural area, more rural area of Frederick, Maryland. How we work with our staff and our primary care practitioners to come about to understand, how to engage the leadership, first of all, and engage leadership not only within the primary care practice itself, but also in the larger city or suburb or rural area. Assessing your readiness. Are you ready? Do you understand? Are you fully understanding of what it will take on to address social determinants of health? We talk about those issues a lot. I mean, even if you saw even in our presidential campaign, many times alluding to the racism, discrimination, health insurance issues, things that that might affect us on multiple levels as a society, but how to translate that into a community level, and selecting and defining your plan as to how to engage in trying to focus on a certain determinant of public health at the patient level. Linking patients to the social determinant of health resources. These are all, again, from both CDC and AMA have multiple levels where you can work within the primary care structure to address social determinants of health. Those are good links that I'll provide later on in this presentation. Evaluating and refining your particular goal or plan for addressing that social determinant of health, whether that be teen pregnancy, whether that be diabetes, hypertension, or whether that be you know, as I said, mental health before. And then finally, after doing the proper research steps and going back and looking at your overall, you know, model of addressing social determinants in your practice, you know, taking the proper surveys to see, having measurable results that will help you to have a complete understanding of how these factors that we talked about factor into daily life and daily practice in a what should I say, a more real and practical way or fashion. So there are many social determinants of health, and each can influence one another. It is best to begin by selecting just one area of focus rather than trying to spread yourself thin and worrying about the whole overall picture without one trying to determine one social determinant to focus on. Also choosing a health outcome or track for which you're going to be making your target, and then also defining your target patient population. So what are the effects of addressing social determinants? Improving health outcomes, improving quality, decreasing costs, and then also overall increasing the work atmosphere, I guess, for healthcare providers. So these are the tools I mentioned a little bit earlier through AMA, and then also CDC, which are Social Determinants of Health Guide to Social Needs, screening tool and resources. The Accountable Health Communities Health-Related Social Needs Screening Tool, PREPARE stands for Protocol for Responding to and Assessing Patient Assets, Risks, and Experiences, Patient-Centered Assessment Method, and then Dial 211 for Essential Community Services, and finally, Workflow Implementation. So these are just a couple examples. I'm not going to go into this in detail because I want to just open it up for the next speaker to go into detail in his particular way, how his, in terms of the public health services. But these are just, I think they had just given a couple of examples where in different cities around the country, they've been practicing social determinant, focusing on specific social determinants of health and how to address them. And they included some major studies in Alameda County, California, Texas, South Carolina, and New York. And I think this is particularly relevant, I think, during COVID right now. We see a lot of interconnections between, you know, in Chicago, for instance, where my husband and my in-laws are from, almost 70% of the city, those who were affected from COVID were amongst in Cook County, for instance, were African Americans. So great health disparities that exist just based upon where you live, your income status, and really your race and your background, unfortunately. You have to meet the patient where they're at and recognize that the goal they might want to set may not be directly related to their medical condition, but looking a little bit further at the connection so that can be made to other resources to address what is really important to them. So that's my introduction for this group setting, and I'd like to hand it over to the next speaker to continue on. Thank you very much.
Shifa, would you please share me the rights to share my screen, please?
Yeah, absolutely.
Thank you.
See how to open this. Mm. Let me see if I can. Put
I'm just requesting.
Yes, I got it. I got it.
Got it? Great.
Yeah, thank you. Go ahead.
Okay, it's still not letting me. Let me see. We might need technical assistance here. I can still cannot share my screen.
Okay.
Let's see. Oh, here we go. Okay. Just need to get some feedback and see everybody can see my screen. Okay, great. Well, my name is Rodrigo Chavez. I'm a Lieutenant Commander with the United States Public Health Service. I work directly under the supervision and direction of Commander Luz Rivera. She is the director for Region 6, regional director for Region 6, ending the HIV epidemic. We are a federal government program that was initiated February of 2019. And what we're trying to do is end the HIV epidemic. And that is part of the program, A Plan for America. This is a bipartisan effort, so that ensures us of continuation through administrations. Part of what we're trying to do, as the name, we're part of a program called Prevention to Active Community Engagement. So we're trying to engage the community in mitigate or resolve some of the issues that are brought about with social determinants of health. One of the key components of our initiative is the expanded patient access to PrEP. It's a medication that is prophylaxis or pre-exposure to HIV, which is a medication that would prevent you from acquiring HIV. Now, with the onset of COVID-19 and HIV, the needs, fear, stigma, loss of loved ones, reduced capabilities of health system, access to health systems have become overwhelmingly exacerbated by the pandemic. So we immediately had to take action and make sure that we activated alternative systems of care like telehealth, telemedicine to immediately respond to the needs of the population and those affected by social determinants of health, like Shifa mentioned earlier. The goals for, I'll go back a little bit, and the goals for the HIV epidemic is to reduce the number of infections by 75% by 2025, and at least 90% in 10 years, which is the year 2030. If you see here in the map, we have several jurisdictions, 48 counties that have been identified as having over 50% of the total new infections of HIV. So every year, about 38,000 individuals acquire HIV, and it has reached a plateau. At that rate, pretty soon, within a decade, we'll have 500,000, about 400,000, 500,000 more new infections. For that, our program was created, and we are trying to create immediate intervention. We are boots on the ground. We're going to, citing the next to last slide by Shifa, we are meeting our stakeholders, doing a needs assessment, identifying gaps, challenges, and best practices, so we in turn create a baseline and take from there steps to improve and eradicate or end the HIV epidemic. The goals are based on 4 pillars. We want to diagnose people as early as possible, number 1. We want to treat people rapidly and effectively. We want to protect those that prevent and protect those that might be at risk of infection. It is very important. And also, there's also a combination of treatment and prevention. Now, if you reach viral suppression, even though there's no cure, if you get the HIV virus under control through medication, that is also a very effective prevention method. So it's treatment as protection. So those pillars combine very, very well. And thanks to the science and the technology and advancement in medical technology, now we can do it. We're also charged with the responsibility to respond. And when I refer to responding to ongoing epidemiological challenges like the pandemic, that's exactly what we do. So we also have to correlate not only fighting HIV dissemination, but also the existing public health emergencies. In this case, a pandemic, but there's also sexually transmitted diseases that can come about. Some areas of our nation, like particularly in our region, Harris County in Houston, Austin, Texas, which is Travis County, San Antonio, which is Bexar County, they had an outbreak of syphilis, which is high, has a high correlation to new HIV infections. So we have to simultaneously respond and keep frontlining the pandemic, and both pandemics, which becomes a syndemic, HIV and COVID, and as well as STIs. So we have the workforce, we are the boots on the ground team, and we're ensuring that ending the HIV epidemic takes place. Now, we have engaged, and that's the key term, like Shifa mentioned, we have engaged federal agencies that are also in the field, in existence, to provide and mitigate the needs in those situations that are aggravated by the social determinants of health. We have engaged the Bureau of Prisons, we have engaged Health Resource and Services Administration, we have engaged the Substance Abuse and Mental Health Agency, the Institute National Institutes of Health, and the Centers for Disease Control. And we have created a collaborative where we're all attacking the same enemy per se. We are trying to mitigate all those factors. Again, it came up and threw really a curve, like in baseball terminology, at us. And now we have to adjust. We have gone through telemedicine, telehealth, and also we have to go into the policy part of how services are delivered. Services are delivered under certain regulations by states, by federal and state regulations. So we had to expand and provide some latitude to physicians to extend how they prescribe medications. Instead of prescribing medications for 30 days, maybe because of the pandemic, they had to go ahead and allow their patients to get 3-month regimens instead of 1-month regimens, and then do a lot of virtual communication. That is part of the adaptation too. Now with the pandemic, also we had other social determinants that came about. Unemployment, people lost their jobs, stress factors. We had to activate mental health service providers and connect them to federal qualified health centers, community health centers, so they could be able to respond and to hotlines about mental health issues that really got exacerbated by the stress created by the pandemic. So we try to fight all battles at one time, at the same time. And also we engage as many providers as we can. We have to exercise policy modification, adaptations, so we can accomplish that. We have also identified, like Shifa did, that transportation, housing, access to service, discrimination are also some of the most notable determinants of health. And for that, we have to make every agency aware that every plan that is in place will continue to be supported by the federal agencies, by those sub-recipients of federal funding. So we have activated a network of support that would hopefully mitigate the needs There's also the uncertainty of how long the pandemic or the crisis would extend. That also creates a lot of mental health issues, not only for the consumer itself, also for the providers. The providers have to go out there and face the potential for exposure, for acquiring the COVID virus. And that also creates a service provider crisis because we're fighting against the numbers. The numbers on one end of COVID positive cases increases, the number of providers decreases. So it's a battle that has to be fought very strategically. In our case, we've noticed that during the COVID pandemic, individuals started, they reduced care seeking behavior. They didn't, that wasn't their priority anymore. They reduced the availability of HIV care, medicine, and diagnosis due to high demand, like I just mentioned. Fewer providers, more demand. ART initiation is the AIDS retroactive antiretroviral therapy for HIV. That was reduced because of obvious reasons. The health services transferred to virtual ports, but it's still for the initial diagnosis, there had to be some hands-on encounters that were delayed because of the closing of the economy or the reduced access to service. Also, the reduction of prevention services. People did not have the same availability, like initiating preventive medication for acquiring HIV, which is PrEP, which is a PrEP treatment. There was a lot of disruption of care at all levels, medical and mental health, because of high demand, and because we're also dealing with something that is completely new. We don't know how COVID works. We're learning as we go, and that adaptation has also taken a toll in our preparation, but the effort continues. Obviously, we had compliance issues because of people's inability to attend appointments, and sometimes they wouldn't trust telehealth or telemedicine because it's something that was introduced abruptly. Now, within a few months, the numbers have increased, with the confidence of consumers or patients has increased as well. So we are on the right path. Now, obviously, we all reduce social contact, and that also creates mental health issues. Social isolation can also be a factor on our well-being physically and emotionally. We continue to encourage the prevention through the use of medication, which is medication PrEP. And we have launched campaigns to continue to motivate individuals through social media, through all means possible, so they know that there's an opportunity to access preventive medication against HIV at free of cost to most of those that request the services. So that's part of the challenge. We also try to expand and pass the word about the importance of continuing with prevention and treatment. We are supporting HIV World Aids activities starting now December 1st, which has been known as a staple of prevention and activity. We will be holding a live event through the Office of Infectious Disease Policy, led by our chief, Harold Phillips, where we're going to address what's new in terms of prevention, in launching as many opportunities nationwide to access PrEP medication for preventing HIV and make it readily available as soon as possible. Now, what we have is the time is now. We have the technology, we have the means to end the epidemic. As we go along, we face housing issues. Some policies exist, like housing opportunities for people living with HIV. We have activated all those resources, but we want to continue to expand. we want to support the effort. Right now, we are, Dr. Rivera and myself, we're in Region 6. That includes Texas, Louisiana, Arkansas, New Mexico, and Oklahoma. But there's two other efforts, one out of LA that covers the southwest side of the country, and the other one over in Georgia that covers 8 states that run from Georgia to Florida and the surrounding vicinity of those states. And this is the original phase. We established an assessment, we made an assessment, we have a plan already, and we are already creating interventions by increasing testing, increasing the use of PrEP, and promoting continuation of those living with HIV are ready to continue in treatment and at one point become virally suppressed, which would render them healthier and also not able to transmit or pass on the virus. At this time, we'll take any questions if you all desire, or we can go, Shifa, into the moderation of the discussion as planned. Thank you.
Thank you so much, Mr. Chavez. So the next actually step was that we just wanted to open it up to question and answer based upon Mr. Chavez's discussion, and then also what you guys already in your own practices and your own particular professional lives, any questions you might have regarding social determinants of health, especially as it relates to the current situation we're undergoing with COVID-19, balancing that with taking care of our particular communities, patients, and co-workers amongst our own staff. So please feel free to ask any questions at this time. I'm gonna turn off my video. So I'm not sure if everybody can hear me, but I was actually asked by Luz to open it up by asking a couple of questions about regarding the issue of stigma, which is the topic of the conference. So exactly what are the stereotypes, biases, what type of I mean, I can even ask with respect to HIV, what prevents the patients from coming forward to the clinician or to your particular provider with regards to these issues in a way that that makes them heard and doesn't make them feel basically as if they're not being listened to. We can start by discussing that topic. There's something wrong with this.
I also wanted to reference a little bit of some of the a couple of encounters that we observed during our visits to different clinics providing HIV care. We have seen how there's a different mentality to coming to access to service. We have gone to some of the waiting areas at HIV clinics, and we see that there are individuals, patients that are very empowered, they even socialize in the waiting room. They talk to everybody, to anybody, they elicit conversation, they start conversations. When on the other hand, You have Latinos that sometimes they go there, they don't want to be seen, they feel completely stigmatized. You literally see them hiding in a corner, looking at the wall, so they are not identified. We also see how some others, individuals come in from out of town because they have their luggage with them. They have a cab or they have an Uber or a Lyft that drops them off, and they stay. They come from distances far away to get their services outside their community. So we witness when we go through those clinics a serious the serious consequences of how stigma can affect access to healthcare. So I don't know. This is prompts a little bit of discussion. Or what would be suggestions that you would have for those settings, those clinic settings, or for those individuals to be able to access care with more liberty, with more comfort? That's just one of many examples that we get to see when we frontline the HIV services in the region.
Thank you, Mr. Chavez. So another question that Luz had asked us to talk about was, research has indicated that stigma associated with multiple circumstances, HIV, mental illness, or sexual preferences, both from disadvantages the stigmatized and is a major source of stress in their lives. We might expect that stigma will also have an effect on population health, similar to other social determinants, such as socioeconomic status, social relationships, such as social support, and racism or discrimination. Do you agree with this, disagree? And are there any examples that we can discuss? Okay, well, I can discuss this from the mental health perspective, having worked in primary care clinics, seeing that many people, you know, just don't want to admit that they have a problem. They don't want to come out and tell the primary care clinician, first of all, that they have been having, you know, outside, you know, for instance, like if they're in an abusive relationship, they won't come out and tell that to the provider right away. It'll come out later, you know, after, like, you know, for instance, discussing that they had fallen down the steps the other day. Oh, and then they had to get spinal surgery, for instance. Well, what happened? They were in a situation that was violent, for instance, with their partner. So that comes out later on, after discussing, you know, many other issues like a headache or just basic other, you know, multiple health problems. So, you know, in the context of like mental illness, domestic abuse, and then also in terms of just patient-provider relationship, those are important circumstances to, and how, for instance, different racial and ethnic backgrounds might perceive mental illness for also. In certain cultures, it's just not as easily spoken about. For instance, in a lot of South Asian cultures, you know, they'll say, like, you know, I mean, you choose your religious provider, you go to your clergy to discuss health issues. You might come also later on to your doctor, but the doctor might not be the first, for instance, outlet, such as a clergyman would. Often those issues are discussed, you know, within family, or else just let, you know, emotionally, like, troubled in their lives for several, you know, months, years, whatnot, before they're even discussed before in front of the providers. That's important. The next question was about how research seems to separate domains within stigma. For example, HIV stigma, or the stigma and mental illness, or sexual orientation and stigma. Do you think that the field of public health could benefit if we develop a theoretical framework on stigma as one of the social determinants of health. I'm not sure if you heard that, Mr. Chavez.
Yes, yes, thank you. I did hear it. We see a stigma as it's almost a collateral effect of acquiring HIV. We witnessed a couple of cases where individuals were more concerned about the social stigma generated by acquiring the infection rather than with the medical challenge, the health challenge presented by it, because the societal impact was really devastating for their lifestyle. And you see it in almost every aspect of care. Individuals that will not allow anybody to send results that would send medication to their homes because of the potential of somebody finding out that those medications would be related to HIV treatment or HIV prevention. So that affects automatically the healthcare delivery system. Obviously, there's also those individuals that with geographically they would not participate in a healthcare system within their surroundings. They would go seek treatment somewhere else. They are also a stigma related to their sexual preference, like we mentioned initially. Latino populations would tell you, a lot of young gay men would tell you that would rather uh, face a cancer or another terminal disease, not so much because of how drastic it is, but because of the impact in their family lifestyle. So that all those approaches or those postures about how people become judgmental and stigmatize homosexuality or sexual preference or access to care simply, that immediately eliminates the support network for the patient. And then they have to resort to alternative methods of support. We also have found out that traditional religion is not necessarily the best option for them to seek spiritual comfort. They get ostracized, they become castigated by the system. Some of the traditional religious groups will say, no, I'm not going to change the scripture that says that a relationship should be men and woman, Adam and Eve. I'm not going to change it because you have a different lifestyle. The scripture is the scripture, and I'm not going to attempt to change it. It will affect accepting you in my community, will affect my standing in front of the rest of my congregation. So they get isolated, they get rejected, and we found out that they resort to alternatives, more accepting worship or approaches, which would be spirituality. They would be accepting more spiritually affirming approaches. So that all encompasses stress that is created through stigma and the mental health challenges, acceptance and societal negation of lifestyles and basic public health realities. So we see that encompassing and revolving around public health, specifically HIV.
Okay, thank you very much for your detailed answer. If there's any other questions from the group of panelists, I'm sorry, I meant to say the group of attendees for the social determinants group. Any other questions related to the topic today, please feel free to discuss.
I would also ask the participants if they have any suggestions for how they see alternatives to end the HIV epidemic, what they see in their communities that works, what has worked as far as acceptance or creating support networks, or not just HIV, public health issue, uh, you know, community health centers, vaccinations now. We might have stress or invalidation of scientific discoveries now with the vaccination for COVID. If what is the field of public health perception of how we're going to gradually resolve the situation of the pandemic? If you have opinions or questions or topics that we can take over. I mean, we work directly for the Assistant Secretary of Health and the Surgeon General, Commander Rivera and I. We like to listen from the community and see what are those topics that keep you up at night now with the pandemic. So we like to take feedback from the community and take it over to the Assistant Secretary of Health. This is a great opportunity because the information that we provide the Secretary of Health is almost real time. And then that's how they make determinations and make decisions for public health strategies.
I had a question within the public health services with regards to specifically cancer care for cancer survivors, cancer patients, and mental health. How much of focus is there right now with regards to social determinants of health on this topic?
Well, actually, the entire effort of the national effort around not just HIV, like you said, it's all cancer and all care revolves about resolving those social determinants of health, because the less, I mean, the more challenges you have, housing opportunities, unemployment, those aggravate any condition regardless of the nature of it. The recovery, reacting adequately to treatment. If you don't have your seeking treatment, like we said earlier, if your basic primary Maslow's pyramid of needs is not satisfied, individuals are not going to seek care. They need to resolve how to put food in my mouth, my children's, feed my children, find shelter. Those are primary needs that are addressed by most agencies have social work teams or service facilitators that address those needs as you move along the care system. And that's what we try to implement and create networks of support within each condition.
Thank you very much. It looks like we have almost 15 participants with us today. Just if anybody has any additional comments, questions. we were hoping to, I believe, at least till 5 p.m. Have the session going. So if any so courageously wants to ask a question, please go ahead.